jiggling and maybe a long axis distraction, hard to do for faster. Or I can do the ultimate Walton, which is scouring, where I look for the catch, the elusive catch. And when I find the catch, I would do a thrust through the long axis. We do another drop piece also. Okay, so the hip is pretty straightforward. I would do the quick release, know the long axis stretch for the prior. Okay. We got next the rib cage. So on the rib cage, we have 3 adjustments. The posterior, we're trying to hit the angle of the rib up or down. The mid-clavicular to mid-axillary line, and we've got the anterior ribs. So I would say concentrate on the P to A, on the posterior rib, and on the anterior ribs. So let me just show anterior one here. So can I stretch your shirt down? Okay, thanks. So on anterior ribs, you want to find, he does all the ribs for some reason, but find one that is painful or prominent. And so we have basically 2 syndesmosis type joints. One's between the cartilage and the sternum, and the other one is between the cartilage and the actual bony rib. So on this, you do not want to do CPR. So you want to be really leaned over the patient. You want to stabilize at the sternum. With a female patient, or you can do it with a male patient, you can have them hold their chest. And then I'm going to have the patient breathe in all the way, hold it, take out all the slack, and then do a thrust. I won't rip your hair off. Let's do a thrust that way, and then breathe out all the way, and do another thrust that way. The trick here is taking out all the slack before you do your thrust. And then you just go with the angle of the articulation. You're trying to distract. So I can go up or down, and then go to the other side and hit it the same way. I do this, but I use an instrument to do it. So let's have you lie on your stomach, please. Okay, use your shirt. Okay, so when you breathe out, the angle of the rib does this. When you breathe in, the angle of the rib does this. So we're trying to hit the angle of the rib back here to either accentuate expiration or inspiration. So this is expiration going up. The angle of the rib goes up, the front of the rib drops down in expiration. So the key thing here is to be on the angle of the rib, not the TP. So here's the spinous process. His TPs go to here. So my contact hand is going to come up and grab a bunch of paraspinals so that here's the spinous, right? So I'm well off of the TP. My stabilization hand, on the other hand, wants to be on the TP to open that up. So what I'm going to do is roll this way. So I have him breathe in, breathe out, really take out all the slack, and then thrust up this way, trying to hit one, or well, more than one angle of the rib on expiration. Okay? Did you understand that without seeing it?
I think so.
Okay. If on the other hand, and this is what most people need, they need to breathe out. Okay, most people don't have a problem breathing in, they have a problem breathing out. So if they do have a problem breathing in, then we would do the opposite. So again, this is trying to shoot along the rib cage, and the assessment here, feel for the sticky spot. And like I said before, chiropractors in general, because of our training, we learn to find spots that are stiffer. Okay, so this is a little stiffer here, so I'll set up there if that's okay with you. So this one's a little bit more uncomfortable because now he's going to be breathing in. So, but I do want to do the same thing. I want to cross over. I'm going to have you breathe in a little bit, hold it, relax though, and then thrust down along the rib cage. One more time. And relax a little bit. Okay. Okay. I have to swab you down to a little bit too slippery. Okay, let's have you sit up, please. So on the ribs, I'm not going to test on the mid-axillary line. Again, you should look at them all. But, so let's go to rib cage. To scapula. So the whole scapular complex. can be stuck down, in other words, it's not going up, or it could be stuck up, not going down and around, or in Walton's world, be stuck 360, anyway. So I'm just going to concentrate on up, down. So this is aptly stretched as part one, as far as you can. Scapula needs to rotate up this way, and I could feel whether that scap is doing it or not. And let's try the other side. Okay, so there's a little bit of give there, but not on the left side. The other assessment that's pretty easy to do for this one is to stabilize in the opposite shoulder and then to lift and see how far that shoulder goes. I'm not finding much of a difference here. So I could hallucinate that the right side's going up more than the left side. So why don't you set up on the left side? That's okay. So I'm going to say this one's stuck down, and then I would have him lie on the side with this side up. Okay, I'm going to be behind him. We would have the head supported. We have a pillow. Thanks. So Dr. Walton likes to get his knife edge underneath because his thumb's messed up. And he gets on the spine of the scapula, and he will cradle arm. And a real important point here, so my knife edge is trying to be on his glenoid. And then what I'm going to do with his scap is tilt it posteriorly, bring it up to a spot behind his EOP. And when all the slack is out, I'll do a thrust. I like to do it this way, because my thumbs are still intact. And let's see if we can get the patient to hit himself in the face. That's always fun. So you take out all the slack, and then you do a thrust over that. Okay, if it were stuck up and not coming down, then I could do the opposite. So I'm going to grab all the way back here. I'm now going to not do a posterior tilt, but an anterior tilt, take out all the slack and thrust down towards the spine. So I'm going to be thrusting up this way or down this way, and then there are other variations on this. Okay, this is a good one. Star this one. How many we got starred?
Is that scapular mobilization? Or is
Yeah,
that
scapular mobilization. Especially the upward one, I think, is probably more common than the
that
lower.
whole thing is scapular mobilization?
Yes, scapular mobilization. Okay, then we have the particulars of the shoulder girdle, the SC joint and AC joint. So let's have you lie on your back. We'll set up on the SC joint. So I think I'm going to skip manubrium sternum. I do that occasionally, but I also do it with an instrument. So on the manubrium sternum, I said I'm skipping it, didn't I? Okay, I guess I'll just skip it. Okay. I'm not going to test you on that.
It's not on here.
It's not on there. Okay, well that's good. I'm skipping the right thing. So the SC joint, the proximal clavicle, might be superior or inferior, or it might be, or it might be lateral or medial. So if it's medial, that is, it is not moving lateral, then I reach over towards the opposite side. And then on this one, I have the option of pushing it either this way, if it's medial and superior, or this way, towards the mid-trap, if it's medial and inferior. Okay, so my line of correction is either going to be towards the mid-trap or basically a little bit underneath the coracoid process. And on this one, it's a real sensitive contact, so you don't want to be heavy-handed about it. I'm going to pick your head up. So you support their head with one hand. I'm going to roll you up. Let me roll you first. If it's medial and superior, I'm going to stand on my superior leg. I'm going to pick your head up a little bit here, please. And then I would have the patient breathe in and out. When their breath all the way out, then I'm going to come in and I'm going to do a thrust that way. Okay? Don't put the contact on and then hold it. Wait till the very end. If it is inferior and medial, then I'm going to reach over. I'm going to shoot this way. Okay. So same thing, breathes in, breathes out all the way. and then I do my thrust in that direction. If, on the other hand, it is lateral, it's not tucking properly, then I'm going to find the notch right here below it. I'm going to grab the scap with one hand, and I would have a pillow for his head, and my line of correction is going to be along the joint line, which is this way, okay, with a breath in his belly. Okay, I'll say to sit up, please.